Hi and welcome from EuroPCR. My name is Simon Redwood and I'm here with John Forrest, who is the PI for the Evolut Low Risk Bicuspid study. John, welcome.
Thank you for having me.
So I guess the first question to ask you is, why is this study important?
Well, when we look at aortic stenosis in general and all of the large randomized studies that have been done, starting with high and extreme risk patients, intermediate and low risk, the results have been very favorable. TAVR has done well compared to surgery, but bicuspid patients, by and large, have been excluded from all of those studies. And so we really, as we move into younger patients, there's a higher percentage of them that have bicuspid valves. And the question of how well does TAVI work in patients with bicuspid valves, I think remains one of the areas where there's a little bit of debate still.
Yeah, of course. So why were bicuspid patients excluded from the trials?
Yeah, so if you look back when TAVR first started and we had first and second generation valves, while bicuspid patients were excluded from the randomized studies, it didn't mean that bicuspid patients weren't being treated. And when we took early looks at how well valves were performing and how well patients were doing, it was clear that patients that had bicuspid anatomy presented a little bit of a challenging situation. And the results in terms of how patients did, in terms of paravalvular leak, device malpositioning, were worse in patients who had bicuspid valves than had tri-leaflet valves. That being said, the devices have changed a lot since those early studies, and that raised the question, with more modern devices, how do we do?
Yeah, anecdotally it seems we get much better results,
Yeah.
having learned a lot about CT analysis and what have you. So how did you do the study?
So the study involved 25 sites across the United States. They were experienced centers, experienced in deploying self-expanding valves. They had all participated in the Evolut Low Risk study. And this study started shortly after the Evolut Low Risk study. We actually waited to start this study until we had moved fully from the initial core valve, which, if you remember, you couldn't recapture and reposition, to the Evolut valve, which you could recapture and reposition. So once that valve was out there, this study started, and in the end it enrolled 150 patients.
Great. And what was the average age of those patients?
Yeah, so the average age of those patients was just over 70. And in fact, if you look what percentage of patients were less than 75 years old, 3/4 of the patients were less than 75 years of age. That compares a little bit differently to the Evolut Low Risk trial in tri-leaflet valves, where the average age was about 74.
And tell me, what were the main results?
So the primary outcome was 30 days, and what we saw was that you got really good results at 30 days. But I think we've now, within TAVI, moved from knowing we can get really good procedural results to trying to better understand what are the longer term results with these patients. And so these patients have all now made it out to 5 years, and the primary outcome, which was all-cause mortality or major stroke, was excellent. So if you look out at 5 years, just over 11% of the patients either were no longer alive or had a major stroke.
And how did that compare to the main Evolut Low Risk?
Yeah, so in the main Evolut Low Risk study, in the surgical and in the transcatheter arms, those numbers were similar. They were less than 15%. They were sort of in the 13 to 14% range. You can't make direct comparisons between the studies, but it does give you a nice framework, understanding, you're around 11% at 5 years for this, somewhere around 13, 14% in the Evolut Low Risk study that excluded them. So it seems to be fairly comparable.
And so you mentioned hard endpoints of stroke and mortality, but how about the hemodynamics? Does that compare well?
Yeah, so I think one of the nice things about a supraannular valve that's self-expanding is that at the level of the annulus where the frame is, which sometimes in a bicuspid valve can be somewhat elliptical, you worry a little bit about how the new valve is going to coap there and how it's going to function. With a supraannular valve, that worry is less, and so when you look at the hemodynamics from this study and compare it really across the Evolut platform, regardless of whether it's a tricuspid valve or a bicuspid valve, the hemodynamics are almost identical.
Fantastic.
Yeah.
So really very promising results. Now, one other thing I noticed was valve thrombosis appeared to be slightly higher, except the numbers are very small and it's an early signal. But do you have any theories as to why that might be?
Yeah, I think valve thrombosis is certainly something that we've come to recognize is an issue with both transcatheter valves and with surgical valves. It's a spectrum all the way from halt to clear valve thrombosis that causes clinically significant issues. Why that occurs, I think, is still an area of ongoing debate. Is it some turbulent flow that's occurring at the level of the sinuses? Does it have to do with bulky leaflets that are there? I think we do know that patients that have bicuspid valves often have different flow in the ascending aorta and coming out of the aortic annulus, and so that may potentially play a role here. I think it also gets to the question of what do we do from an antiplatelet, anticoagulant strategy for these
And we
patients.
just don't know.
And I mean, this is where we need more data.
Yeah, absolutely. Well, thank you very much. I mean, my take home on this is that I know you said the numbers are small, but it is a complete data set, 150 patients with decent follow-up, 5 years. And certainly looking at the data, bicuspid, treating a bicuspid valve with the Evolut platform seems at least as good, if not even possibly better than tricuspid valves in these patients. So we need to really continue the follow-up for much longer. And I know the main study is going out to 10 years. Are you planning on that with these patients?
Yeah, we're definitely, absolutely. We're going to follow these patients out to 10 years, try to understand what happens over the longer period of time. But I agree with you. I think that less should be looking at the specific number of leaflets, but probably a lot of other characteristics that go into deciding whether a young patient or a low-risk patient would be best suited with a transcatheter prosthesis or a surgical prosthesis. And I think some of the questions that we have in bicuspid really expand more across the spectrum as it relates to TAVI.
Great. Well, John, thank you very much for joining me today.
Absolutely. Thanks for having me.